Hello and welcome to week 4 of PUBH 612. Today we will review the public health methods and how we define and characterize a health problem. This week we will briefly review the different types of public health methods and the strength of their evidence. We will also discuss how to develop a causal theory and statement for a health problem, how to apply basic epidemiology to quantifying a health problem. You may have seen this chart in your epidemiology class. In public health, studies can either be observational, such as a cross-sectional study which provides a snapshot of individuals at one point in time and can be useful in describing a population, or a cohort study, for example, which follows a group of individuals over a period of time. The other arm of the graph is experimental studies, such as randomized controlled trials, which will randomly allocate individuals to treatment and control groups and observe outcomes. It's important that you familiarize yourself with these different types of study designs and are aware of the strengths and limitations of each. Here you see the pyramid of scientific evidence. You'll notice that observational studies, such as cross-sectional, case control, and cohort studies, are lower quality evidence than randomized controlled trials, and they have a higher risk of bias because participants aren't being randomized. You'll also notice that systematic reviews and meta-analysis, particularly of randomized controlled trials, sit at the top of the pyramid of evidence because they're gathering all of the evidence across many studies and combining it to give you the best picture of what the current knowledge base is in the field. In this lecture, we're going to focus on data which could be used in a community health assessment. Public data are typically a good starting point because they're free and open to the public, and they include things like vital statistics, census data, and large national studies such as NHANES. These data can help to identify target populations and help decision makers make health policy decisions. These data are helpful, but they may be several years old, and sometimes you're going to need more specific information about your community of interest. And this is when you would go out and collect primary data, such as by conducting surveys or maybe focus groups, key informant interviews, etc. And this would give you more information about the specific health issue and how it's perceived or maybe experienced in your population of interest. Other useful data could be gathered just by walking through a community and observing perhaps the number of abandoned buildings, fast food restaurants, advertisements, what types of things are being advertised in your community. This unobtrusive data collection method can reveal strengths and problems in a community. And there's a link at the end of the lecture to the community toolbox where you can find more information about how to collect observational data for your community health assessment. Another type of data is archival data, and this includes agency records, newspapers, and other reports, but these data are not current oftentimes, and they may not be complete or cover exactly what you're looking for because they were collected for another purpose by someone else. Proprietary data is data that are owned by an agency or a company, and they can be purchased, such as health insurance data. It will be interesting to see how proprietary data is regulated and used in the future as we are increasingly using cell phones, Apple Watches, and Fitbits, and the incredible amount of data about us that is captured on those devices. Published literature is also a great place to start when researching a health issue or community to see what has been previously published. This information is readily available and free or inexpensive. So sites like PubMed, and please see the CUNY LibGuide on how to access all the different databases and most effectively use our library resources which are available to you. Lastly, there are other sources of data which may not be easily accessible, such as information on hard-to-reach populations, and you're going to need to go out and conduct a focus group with them to understand their unique barriers to healthcare or their role in the community. Here are some statistics we use to describe health problems. The first are descriptive statistics, and you are probably very familiar with these as they are easy to calculate and they're often used to describe a population. The frequency or count of an occurrence, such as number of deaths due to cardiovascular disease in a population, and from this count we can calculate the average and range of values or standard deviation in a population. In order to estimate the likelihood of having or getting a disease, we can calculate the odds ratio or the relative risk. In order to calculate the odds ratio, you must divide the odds of being exposed to the disease by the odds of having the disease. Please review the definitions for each of these terms and familiarize yourself with how they could be used and interpreted. You'll find detailed descriptions of each in your textbook on page 100 and 101. And your ability to understand these statistics and use them to describe a health problem in your community is an essential step in conducting a community health assessment and a primary component of public health work. Since the statistics we use to describe health problems are based on numbers, having too few of them in your analysis is a big problem. For example, if your community is small, say a rural community, the denominator is small, and therefore any change in the occurrence of the health problem, which is your numerator, will lead to a large change in the rate or proportion of the health problem. Another concern with small populations or small sample sizes can be concerns about confidentiality. In a very small community, someone might be able to identify who has the disease, even if the data are de-identified. One way to overcome this challenge is to pool multiple years of data, or you can compare the proportion of disease in a smaller population to a larger community, which could serve as a standard. When collecting or reviewing existing data for a community health assessment, the magnitude of the health problem will certainly be something that you need to consider. Incidence is the rate at which new cases of disease occur in a community. New being the key word here, while prevalence is the extent to which cases of the disease currently exist in a population. For example, the number of new HIV diagnoses in the US in the past year would give you the incidence, while the percentage of the population in the US that has HIV is the prevalence. When we consider a health issue in a community from an epidemiologic perspective, there are three things that we must consider: the agent, host, and environment. These three things make up the epidemiologic triangle. The agent is the what, the cause of the disease. When studying the epidemiology of most infectious diseases, the agent is a microbe, such as a bacteria, a virus, or a parasite, aka a germ. The host is the who, humans or animals which are exposed to and harbor disease. The host includes different reactions that people have to the same agent. For example, adults affected with chickenpox are more likely than children to develop serious complications. And the third point on the triangle is the where, the environment, that cause or allow the disease to be transmitted. For example, dirty water, which allows cholera to thrive. Population characteristics relate to the social aspects of a population, such as income level, education level, occupation distribution, etc. The socioeconomic makeup of the community that you're working in could dramatically influence health risks. Lastly, attitudes and behaviors of the population being assessed are important factors to consider. For example, distrust of medical professionals may lead to individuals avoiding needed medical care, or high rates of smoking would lead to higher risk of morbidity and mortality. The combination of these factors enables us as researchers and/or evaluators to hypothesize about what causes a health problem. Here, you can see the same elements presented in a visual, which can help you to map out your health problem and what factors may be moderating, or in other words, factors that would have the potential to exaggerate or lessen the health problem. Or mediating factors, which sit on the causal pathway between your exposure and outcome. And without this factor, the exposure would not result in the outcome. For example, if the exposure is stroke and the outcome is death, the quality of emergency medical care is a mediating factor. Here is a clip of a table from your book which provides an example of the elements of a causal theory as they relate to adult vaccinations. And here are those elements which have been inserted into a causal theory diagram. You can see that age is an antecedent factor because we're interested in adult vaccination rates. One of the main causes of vaccination is perceived vulnerability. So for instance, I live in Rockland County, which is one of the centers of the current measles outbreak. So my vulnerability caused me to make sure I had the measles vaccine. This was moderated by my knowledge about measles and the fact that when I went to my prenatal care, they told me I no longer had immunity from my childhood measles shot and needed to be revaccinated. This increased my likelihood of getting vaccinated. These factors are mediated by the fact that vaccines are free and widely available in my community, so I'm able to get them. Once you've done your research and identified which health problems are most prevalent and important in your community, you will need to prioritize the health problems so you can identify which one of the programs, interventions, evaluations you should focus on. While this may be done for you by a funder who has given you a grant to address a certain health issue, if you do have to select and prioritize a health problem, there are several ways of doing this. The first is the nominal technique, which involves gathering a small group of stakeholders and conducting a round robin where you vote and narrow down the list of priorities. Another approach is the basic priority rating system shown here, which incorporates the magnitude, seriousness, and the intervention effectiveness into the consideration. Another method is the Pearl method, which includes economic factors, the acceptability of the intervention, resources available, and legality. Lastly, a program can be prioritized based on the importance and changeability of the health outcome. The table shown here outlines how to prioritize a health problem based on the importance and changeability. As you can see, the health problems that are highly important and have an effective intervention are the highest priority, shown in the upper left box. An example of a highly important health problem with a very effective intervention is HIV and antiretroviral medications, which can now result in people being undetectable and the virus being untransmissible. In week 1, we talked about the public health pyramid and the different levels at which public health work can occur. At each of these levels, there are different types of data that can be used to prioritize the health problem. Direct services data are probably some of the most common as they come from individual patients through surveys, electronic health records, etc. Because the information captured is from individuals, the health problem statement tends to be for a small, highly homogeneous target population and address a personal, episodic issue. At the enabling services level, data are coming from the community through things like local news and service organizations. As we talked about earlier, other types of observational data done during a community mapping exercise would also be used here at the enabling services level. These data can be sorted into various elements of the health problem to help determine what should be included in the health problem statement. For instance, if you're interested in addressing obesity, data could be sorted into information related to food in the community, environmental factors that would impact exercise, economic or transportation information, etc. At the population level, data are typically coming from epidemiology and trend analysis to determine the urgency of a health problem. The factors in the health problem statement apply to the entire population and would include factors affecting the environment, which could be physical factors such as the built environment, or social, such as social economics. At the bottom of the pyramid in the infrastructure level, the data are coming from organizations, legal or workforce records, and these characteristics can be sorted into different elements of the health problem and can serve as a check on potential barriers and facilitators of the program. So in summary, there are many different sources of data which can be used in a community health assessment. And you as a public health professional should be familiar with the limitations and potential use of each, and at which level of the public health pyramid it sits. In order to understand a health problem in a community, you need to understand the epidemiology of the disease and be able to describe the magnitude of the disease and draw a causal diagram about how different factors may be impacting the disease. Please make sure you review the different study designs and statistics used to describe health problems so you're using data appropriately. Remember that logic models are used to organize the delivery of a program, while a causal model of a health problem focuses on understanding the root causes of a disease and the mediating and moderating factors. Lastly, these last two slides are some internet resources which can help you find additional information about community health assessments, statistical tests, and the community toolbox, which I mentioned earlier. Thanks and enjoy the rest of your week.